Hello, everybody. We'd like to welcome you in, and hopefully you'll find the information that we'll be sharing with you very helpful in this ever-changing environment that we're in right now. Of course, we must start off with a disclaimer that all this information is the best that we know as of today, but as of this afternoon, some of it may not be valid anymore. So I'm just going to jump right into the billing of telehealth services prior to the public health emergency. So we knew there were just two parts that went to this. It was the distance site and the originating site. Distance site, where the provider's located, how you had them enrolled with Medicare Part B group. And then the originating site is that the patient had to be in a rural HIPSA area. It might have been in a hospital, a clinic, or a SNF. So of those two distinct parts, the billing for the distance site was on the UB CMS, 1500. We used a place of service 02, which paid at that lower Medicare physician fee schedule amount. We then listed where the provider was located in box 32, and RHCs were unable to participate due to needing a face-to-face requirement that wasn't met. For critical access hospitals, then when we talked about the originating site, you did bill on the UB, the revenue code 780, the Q3014 meant that it was a telehealth service. If it was an inpatient, this is just a note to be sure that if ever you're providing telehealth services to an inpatient, you must submit a separate bill for that, because otherwise it's not included. You're not getting that extra monies for the telehealth visit originating site, because it's not included in your daily rate. So there were virtual communication services that the RHC could bill. And this goes back to January 1 of last year. Not a lot of people were using it because it was a very limited reimbursement. So whenever you had 5 minutes or more of communication-based technology where the patient didn't have a billable RHC visit within the last 7 days, and that it didn't result in you having the patient have to come in within the next 24 hours or your next available appointment, you were able to bill this G0071, and it paid you approximately $13.53. So the public health emergency, a lot of people might not be aware, because we didn't see a lot of discussion about it early on in the United States here, but it was signed in January 31st of this year. But then March 13th is where we really started seeing some activity with this, with waivers and modifications. Our first, really where we first became aware of it, was with the 1135 waiver that went back to March 1st. And what was different about these waivers, as with other times when there is public health emergencies, is that because it was nationwide, you did not have to apply for the waiver. So it's just a blanket waiver that all of the public information covers. So for SNFs, what it allowed is that the 3-day qualifying stay would be waived. Now, that doesn't mean that if it's not in as a result of the public health emergency that it's being waived, but it did cover cause, acute to swing bed. If your patients were being moved prior to a 3-day stay that they would have normally had because of evacuation, transfer, or dislocation, then that is being waived. Home health, there were some exceptions in the timelines for OASIS, and then MACs can extend that cancellation date of the wraps so that to give you more time to get those things taken care of. And then the critical access hospitals, the beds were not limited to 25 beds. If you have a need in your area, and the length of stay could exceed 96 hours, and all of that information can be found in this link that we have attached here. So one of the things, we kind of laid out this grid to help us think about what are all the things that we need to think about as far as the telemedicine consideration. So we have goals, obviously to minimize the exposure to the patients and the providers. You have to keep in mind that each state may have its own laws or professional practice limitations. So you do still have to follow what your state requirements are. Be sure of your definition of service. You know, we hear telehealth and telemedicine, you know, are often kind of all lumped into one. So within your organization, be sure that everyone's very clear on what services are being provided as we kind of go through what the billing is for that. The provider of service, you know, your qualified providers, who that includes. And then there are some other practitioners that are also allowed to bill some of these services with, as long as it's within their scope of practice. One of the things under that certain other practices within the scope of practice in that fourth column at the bottom there is PT, OT, and ST, the physical therapy, occupational therapy, and speech therapy. There's been kind of a lot of confusion over what can and cannot be billed. When you look at the list of things of what can be billed, that does not mean that the therapists are eligible to provide those services. So you'll want to check on that. And then the setting of the service. So here we've kind of broken down, when we think about telemedicine, there's three parts. And there's the virtual visit, which are kind of your telephone call, CPT type codes. There is a Medicare code that we'll talk more about, G code. And then telehealth is really just what would have been the services provided face-to-face with the patient. It includes audio and video because you have to be able to communicate with the patient. And there's also e-visits then, and those are the things that might come through a patient portal, such as a MyChart or something like that. So the workflow of the telemedicine, we kind of have your registration of your visit. You know, we need to be able to clearly distinguish between what was an actual patient visit and what is something that's going to fall under this virtual telehealth or e-visit. You know, identifying that patient. Do you have something set up in your system to separately identify these patients? Because you may have some patients coming in, but then other patients are being provided telemedicine. So just because you would register them, let's say in your clinic setting or in your hospital outpatient area, maybe in an urgent care, we need some way to identify between the two different types of services. And then that patient consent, you know, be sure you have developed a plan and scripting, you know, because we do still need a consent to treat. It doesn't have to be done by the provider, but it has to be obtained prior to the treatment being provided in order for us to bill. And just thinking about all of those consents, everything that you need within your organization, how are you going to handle those type of things? And, you know, the telehealth, virtual visit, and e-visit, we kind of put a little more description under those here for you. So the key things in this is the documentation. You know, everything from how are we registering, what is the responsibility of the ancillary departments, nursing departments, who's going to be responsible for each of those pieces, and then thinking about from a provider standpoint, have we developed a different template that they use for an actual face-to-face visit as opposed to when they have a telehealth visit that's going on. From a coding and billing standpoint, being able to understand that in the past we may have billed for the originating site, but when the patient is in their home or another location, we're not going to be billing for that. So if you within your system had it set up that whenever previously you provided telehealth services, it would automatic kind of what we call an explode of a charge, and it would assign that automatically. We want to be sure you turn those things off because you can't bill for that originating site unless the patient is physically present in one of those locations. And then the reimbursement and payment. You know, the importance of modifiers, condition codes, if you have to put comments on the claims, you know, being sure that we not only have our billing system set up, but then also through our clearinghouse, our electronic health record, and all of those type of things. So it's really just kind of laying out here what you need to have in place. Okay, so now we're going to kind of move into, let me close that down there. We're going to move into billing during the public health emergency. So there has been changes. The patient doesn't have to be located in that rural area. They do not have to be an established patient. They can be a new patient. And the provider can be present in some place such as their home. So if they're self-isolating, that's what they can do. And you're going to bill your place of service as if the provider, where the provider would have normally seen those patients. There's some new condition codes that the payers may require, such as a DR to be on the UB04, and that it just lets the payer know that you are billing this under a waiver. The modifier 95 is being used by some payers. Medicare is billing it for professional services to tell them that it's been a synchronous telemedicine visit. So when you bill your E&M or anything that is on that list of covered services, that it's letting them know we weren't face-to-face, but we might have used Zoom or FaceTime or Skype. Some of the things that you want to stay away from are those things that are social media, such as Facebook Live, Instagram, TikTok, things like that. And remember, this is for right now during this public health emergency. The leniency that's being put on what can be used will definitely change. The CR modifier is going to be reported on your 1500 claim form. And the CS modifier are for services that are related to the cost sharing waiver. So a lot of states have come out with rules, as well as Medicare has said that from March 18th on until the end of the public health emergency, they will waive copays and deductibles for Medicare patients. Then it's going to pertain to the test and any of the E&M or facility fee that's related to when that patient is being seen, that is going to result in a test being ordered for that patient or further testing being done. So beginning with March 18th on, you're going to put on the CS modifier, and what it's going to do is waive the coinsurance and deductible due from the patient. So one of the things that we think is would be beneficial for organizations is to take a look at building some type of a grid. And I'm using this as an example of the different kinds of visits, so the e-visits, virtual visits, or telemedicine visits, and indicating what's covered, what's not covered, what the place of service is that they want on the claim, what modifiers may be required on the claim, and then if when the COVID-19 screening is being done, resulting in that, are they going to waive cost sharing, yes or no, so that you know, should we collect or should we not collect? So as you can see here, there's kind of a variety of payer information here, and we've got the Medicare RHCs to know how to bill through June 30th and then through July 1. And we're going to talk more about those changes as we move through the presentation here. You can see that Cigna wants a place of service 11, where other payers do not want the different places of service. So on the Medicare RHC telehealth services, per that CARES Act that was effective March 27th, so it goes back retro to January through June 30th. The originating site, again, there's going to be no charge for that because the patient, unless the patient is in your clinic or hospital setting, could be a SNF as well. The distance site, providers can be temporarily located in those wherever they are. It doesn't matter. It doesn't have to be a location. And so you're going to bill with the location where the provider would regularly be scheduled. Services must be within their scope of practice. And then we've got the link here for what different services are covered under that. For RHCs, you're going to bill that up through June 30th with the E&M code and the 95 modifier appended to indicate that it wasn't a face-to-face visit. And you're going to initially be paid the all-inclusive rate. And beginning July 1, they're going to automatically reprocess these claims to adjust it down to that $92 limiting amount that CMS has put out there. So at that time, Medicare is not going to be paying your all-inclusive rate. You will receive 80% of the $92, which will be $73.60, leaving the coinsurance amount of $18.40. You will put on the CS modifier if that visit resulted in the ordering of the COVID-19 test, at which time there will not be a coinsurance assessed. Now, again, CMS isn't going to be able to process, or the MACs aren't going to be able to process our claims that way until July 1st, when the next quarterly release comes out. So at that time, you can expect that if you have a claim with the CS modifier on it, it's going to process, leaving coinsurance. Then effective July 1, they will reprocess it, pay you at 100%, and they will take away that coinsurance amount that they had originally established. So you can expect that you will be refunding secondaries when they automatically crossed over on that initial claim submission. So effective for the virtual communication services that we talked about before, where the payment was $13.53, beginning March 1st, they've expanded this. So in the beginning, they took the national average of just the codes G2010 and G2012, but now they've expanded that to include the 99421 to 99423. And so any, per the SE Medicare or MedLearn Matters SE 20016 that was released on April 17th, they're going to go back to your claims that you submit from March 1st on with the G0071, and they will reprocess those and pay you this additional rate of $24.76, because that's what the new rate is effective March 1st. So that reimbursement is going to result in some additional coinsurances being due. So originally 20% of the $13.53 was $2.70. When they pay the new rate of $24.76, that coinsurance is going to change to $4.95. That's going to be approximately $2.25 that will then be left on the accounts. And because we know that they will have paid, taken back their payment, reprocessed to the secondary payer, it looks like an adjusted claim, which don't automatically cross over. So you can expect that your revenue cycle staff are going to have to deal with balances of $2.25 for every one of these claims submitted up until July 1st. So the new revenue code, effective July 1. So CMS has said, we're not going to pay you all-inclusive rate to the RHCs. We're going to pay you this $92 rate. So effective July 1, we'll be submitting claims with the G2025 on it. And every RHC is going to get paid regardless of your existing all-inclusive rate. So because we know that for freestanding RHCs or RHCs associated with hospitals over 50 beds, there's been a limiting fee of $86.31. That was the most you were going to get paid. So you can expect to see additional payments on these claims effective July 1. And per the MedLearn Matters, it states this is for telehealth distance site services furnished between July 1 and the end of the COVID-19 public health emergency. But what we don't know is, because it says effective July 1, we don't know if you have a claim, let's say from June 28th, that you don't submit until after July 1, will we be able to send this G code? And there's been a lot of discussion if a rural health clinic is in a financial situation where they can wait to submit their claims. Is it possible to not bill any of those Medicare claims and wait till July 1 so that they pay correctly the first time? You know, we don't have that direction yet to say that July 1 they will accept it for any date of service from March 1 to, you know, on. So, you know, we're still kind of waiting for some direction on that. Because the other thing that wasn't addressed is when we use the G2025, is does the CG modifier have to go on that claim? Typically in rural health clinics, when we bill chronic care management and we bill the virtual communication services with the G0071, we don't have to put on the CG modifier because we're not getting paid the all-inclusive rate. So stay tuned for that as well, because that instruction has not been released either. I'm going to move here to some recent information and change on the uninsured reporting. So you will be able to get some payment for those patients that for services that are related to COVID-19 that have been found to be uninsured. So per the Families First Coronavirus Response Act and the CARES Act, there is a timeline out there where this can happen. So if you indicate you've exhausted all efforts to getting a patient signed up to Medicaid, there is no insurance out there at all, that effective with dates of service of February 4th, that you can submit those. So this program launched on April 22nd. The enrollment began on Monday, where you can go to the portal, and enroll yourselves. The interesting thing is that the portal opened, but they haven't provided any training on it, and that's supposed to start today. So that providers know how are we going to submit this information. So May 6th, you're supposed to be able to begin electronic claim submission through this portal, and then expect reimbursement for those claims mid-May. And the provider, when you're submitting that, you are attesting that the patient is not covered under any other program, and you will not balance bill the patient. You are going to accept Medicare payment as payment in full for those services. So the things that would be covered is the specimen collection, the diagnosis and antibody testing, any related visits. So whether you're seeing that patient through the office, urgent care, ER, telemedicine, any of those services for an uninsured would apply. And again, it's just with those dates of service after February 4th. It would include inpatient, observation, skilled nursing, home health, DME, all of those things, as well as when a vaccine comes out, that also could be covered under this uninsured patient. So the things that aren't covered is air and water ambulance, any treatment that you provide to uninsured that does not have the diagnosis, except for pregnancy, where the diagnosis would need to be primary, except in the case of pregnancy where it would be secondary. Hospice services are not going to be covered, nor are any prescription drugs that would be covered under the Medicare Part D. It can be submitted for any patient in the US, and it's going to be based on your current year's Medicare rate and based on when the services were, at the time that the services were provided. And we anticipate that we will be seeing some new codes or updates to existing codes that may be reported for that. So if CMS comes out with some new codes, such as the G2025, or codes that they say we'll pay on these, but not until the next quarterly update, that's where you would find that. And here we have the link for what those would be, all those rules under there, but we do expect some additional instruction on that to be coming out. So just from the revenue cycle standpoint, is thinking about what we get paid prior to July 1 and what we're going to get paid after July 1. So have some documented policies and procedures in place so that you know how you're going to handle those. Because if your accounts receivable, or your all-inclusive rate at this time is significantly higher or higher than that $92 that they're going to reprocess your claims, you're going to want to be making a reserve for those accounts, because that money is going to be recouped when those claims start getting reprocessed. And then the things that we talked about, expect that you're going to have some secondary insurance issues with all these reprocessed claims for not only telemedicine visits, but anything that you're billing as the virtual communication services under the 0071. You know, those CS modifier claims where they should have waived the deductible and coinsurance, but they didn't, and the secondary went through. And then just be aware there is a remittance advice remark code that is currently available on claims that we may see more of, and that's the N776, saying that this service is not covered as a telehealth type of a service. The sequestration, you should start seeing that not being assessed on claims from May, or with dates of service May 1st, and they have said that that's going to be through the end of the year. That sequestration, they're just going to extend how long it will be in place in subsequent years. And then claims processing, expect that your discharge not final billed is going to grow, because you're going to be holding some claims, maybe awaiting test results, so that you're putting those, that you're accurately reporting those. Your charge masters, your electronic health systems, you know, modules, be sure they're updated so that all of the modifiers, the place of service, everything that the claim follows through the system. We recommend when you first start using these codes that you look at, not only did we build it in our charge master, the documentation supported it, it dropped to our bill, it got through our clearinghouse, and it got through to the payer. So just keep in mind that those things that we talked about that are during the public health emergency, this is temporary. Keep documentation of what changes you've made to your system, because things are going to go back to the way they were. We believe that the consensus in the industry is that some of the things that are being covered under telemedicine that weren't previously, some of them may stay, but definitely not all of them are going to stay. And when these waivers expire, we have to go back to business as usual.
Welcome. This is Ralph Llewellyn with iBailey talking now. I'm going to talk about more of the funding and cost report considerations. So let's start talking about just some of the things that we know from that reimbursement cost report side of things. A lot of the questions we're getting are around how to record expenses. Those expenses that may be around COVID, new expenses, additional expenses above and beyond, planning, things like that. And in our recommendation overall is that make sure that you continue, or at least consider, to continue to expense those to the department or the area where they're providing service. And the reason being is that ultimately on the Medicare cost report, these are still going to have to go back to the service departments to match revenues and expenses within the individual departments. With that, if you have employees that you're reassigning from one department to another, either permanently or semi-temporary through the emergency, you're going to want to make sure you have an avenue to expense those expenses to those departments. If somebody in nursing is now spending time doing something more administrative or something in another department, you're going to need to get that expense in those right departments. So a couple of considerations there: continue to put it in the department. That seems to work out well. I know a lot of providers, as we're talking to them, are really looking at having some sort of a breakout within their department, though, that does separately identify those expenses that are related to the COVID emergency. So this might be some sort of subsidiary ledger, some sub-accounts within the department. So that way it allows you to have what you need for the Medicare cost report, at the same time, going into handling all of the tracking that we're going to have to do along the way. Because, if you lump it all together, it's going to be a real hard time deciding where it goes, because so much of it has to do with individual department planning, etc. Really not looking to set up a separate cost center, because then we got to figure out how do we get that allocated. Is that an A&G expense? Is it related to the whole entity? Is it related to a sub part of the entity? That's going to be a real challenge as we move forward. As we look at the other part of it is that, what happens if you're receiving reimbursement? Because you're getting reimbursement from HHS, you're getting some SHIP funds, you're getting all kinds of different revenues flying from different areas, and not always a lot of revenue, but there's a lot of different accounts. And what we really want to see providers doing, and what we recommend they do, is look to put them into a separate account. Have a separate account that's not just your all other revenue that you put everything else in all the time. Maybe it's another COVID revenue account, or maybe it's a different account for every type of reimbursement you've received. Because right now, the problem is we don't know exactly how Medicare is going to make us treat this. So there's a lot of conversations out there, for some of these things, such as, what we're getting from Health and Human Services, is that a grant? Many of us would say, yes, that's a grant, should be not offset, not subject to offset on the cost report, but we need to make sure that we know where those dollars are for at the time that we get some sort of final confirmation from CMS there. The loan forgiveness on PPP, well, is that going to be considered a rebate? Is that going to be covered a reduction or a recoupment of expenses? Again, we want to make sure we understand where all that comes from. And the most important piece here is because all of this has happened so extremely quickly as far as the dollars getting out. We've never seen Medicare and HHS get dollars out this fast. We just don't have a lot of the clarification. So we want to make sure that we're preserving all of the detail that we're going to need eventually down the road. Next piece that we want to talk about is accelerated or advanced payments. The most important piece here is just to say, if you haven't gotten it yet, you're probably not going to, because they suspended these immediately on April 26th. So came in from the weekend, and that's what was sitting on the desk, saying absolutely no new applications, and they're reevaluating all pending and previous new applications. And really what they're looking at there is, because of all these other funds that are coming through, they're starting to question, from what we can read into it, is there a need for this advanced payment on top of all the other pieces? Stay tuned on this. It'll be interesting to see if there's some pushback on that to get that reopened. But at this point, that has been suspended. We are seeing a lot of conversation in different blogs, different industry groups about, the eventual forgiveness on the payback of these accelerated payments. And I guess what we would guide you there is that there's absolutely nothing out there at this point that is official in any conversations. I haven't seen anything from anything in Congress, from either the Senate or the House or any of the major groups out there that typically try to help model the legislation. It's more providers that have been talking about this. I would recommend, as you're planning and looking to the future, that you do that proceeding as if the amounts are going to be recouped from Medicare based on the way that they were originally noted. Let's go to the RHC telehealth cost reporting. This one, obviously, there's a lot of concern because we're getting paid the $92 in the long run. We're not getting paid our all-inclusive rates, and we all understand those concerns. The other concern we have around that is that we need to make sure that we're tracking these expenses correctly then also for the Medicare cost report. Because while you're not getting the AIR, we also have to make sure that the cost isn't ending up in the RHC component of the cost report that calculates your future all-inclusive rate. These costs need to be separately identified if you have a rural health clinic, and we need to break them out in a manner that would be similar to what we're doing if we're doing chronic care management and virtual communication services. Now, I have some providers saying, well, we're not doing anything right now for chronic care management and virtual communication services. That's just another concern, because on the cost report, you should be providing that as you're preparing your cost report, because that expense comes out. And eventually also, as you look at calculating your FTEs, and you do your FTEs aren't going to include the time that they were doing telehealth. How that's all going to impact the whole productivity standard and the application and everything, that'll vary depending on how much time you're spending on the telehealth visits. I'm sure at the end of the day, we're not going to see any of us thinking that we're getting ahead because of this. We're going to be falling backwards. But you're really going to want to make sure you track that expense, pull out the FTEs, make sure you're not over calculating that productivity standard. So at the end of the day, you're going to get the reimbursement based on a fee schedule, as Dion noted. Let's talk a little bit about the productivity standards. We've been getting a lot of questions. Here's kind of the question that we've been given here is, given lower payments, would CMS grant blanket exceptions to the RHC standards? And currently there are no blankets. You could request an exception the MAC, which has always been an option out there. But just in the last few days, we've found some stuff on the Noridian website that talks about the fact that RHCs have had to change the way that they operate. You can see the wording here. The important piece here is it says to minimize the burden on RHCs, the MACs may choose to proactively grant productivity exceptions to RHCs who have experienced disruptions. I think the key here, the piece that we should be looking at as providers here, is really starting to push the MACs to say, hey, let's get this done proactively so that each one of us doesn't have to individually go out and make an application to get this productivity exception done. Other considerations, if you're looking at reduced hours for your practitioners and they're not available to see patients, can we pull those hours out of the FTEs so we're not getting penalized there? Some questions about how the MACs would look at that because there's still costs there, but not time in that productivity standard. Definitely some things to continue to watch. The biggest action item here is let's start pushing the MACs to get some sort of proactive productivity grant exception. So that'll be the piece that we want to go there. Let's talk a little bit about the Payroll Protection Act, or the program. $310 billion in new funding. The biggest thing I would say here is apply quickly. We told people this in the first round. Some were waiting to figure out what else was going to happen, only to find out by the time they got to the line was shut off. We don't anticipate these funds are going to last long, and we don't anticipate this time that they're going to be funded again. That's been the one piece that we've heard from a couple of different angles, that this is the last time that piece will get funded, or at least there's no plans to do that. So some things there. If you are a governmental entity and you were originally declined to get a PPP loan, I really recommend you go back and look at some information. This is some question that came back answered through the NRHA about talking about how hospital-owned entities, governmental entities, could actually be applicable. And so what I would say here is I'd go back to your SBA if you've been turned down before, try to get it approved. If you can't, show them this information. If you still can't, there is definitely a lot of attorneys out there that we've worked with that can help you get that piece pushed through. If you don't know who to talk to from an attorney perspective, drop me an email. I'll get you some ideas. We just want to make sure if this is an option for you and you were told no before, let's make sure that we actually take advantage of it if we can get that. So let's go to the next piece here. Now, a lot of you have gotten your money. And so now the next piece that we're talking to people about, and we really got to start hitting hard on this, is starting to plan your strategy of how you're going to document your forgiveness. How are you going to maximize the amount you can do? So when you think about what you're going to have to do here, you need to look at collecting original loan data, historical payroll costs, actual and estimated covered costs, so you can kind of figure out where you think you're going to land from a forgiveness perspective, employee and compensation details. This really helps you develop the plan for the of how you're going to, what documentation you're going to have to gather. It helps you calculate an estimate of what your forgiveness may be when you get to the end. And so we have a lot of providers that we've been working with where maybe their forgiveness isn't quite what they thought it was going to be, and we start talking about strategies of, there's some things that make sense to do that might help you maximize that forgiveness, maybe be able to help take care of some expense things that you were hoping to do for staff, different employee groups, etc. So definitely some things there. The biggest piece here is explore and create strategies. And the other part is as you start tracking this, don't forget that there is a relatedness between this and all the other fundings, because as you start to have to prove how you spent the money, you can only spend money once. They're not going to be allowing you to double dip. A lot of times what we're finding is if you can identify the dollars and cents to be tracked to the payroll protection program, that's the hardest one to get something tied to. It might behoove you to put it in there versus somewhere else and start working out how you're going to track and protect those other dollars. And then just one thing that came up since we set these slides up yesterday, the Treasurer Secretary commented on the PPP loan program regarding auditing loans over $2 million. And from that conversation, it sounds like they will perform the review before granting loan forgiveness. So, and as they talk about, they're talking about focusing on applicants' cash flow and liquidity needs. So our recommendation here is, on top of just tracking where you're at with the forgiveness calculation, is really recommend considering preparation of cash flow and liquidity projections to help support your cause for that whole forgiveness. Provider relief funding. This is that whole big bucket that started out with 150 billion or 100 billion. Now it's going to be up to 175. But let's talk about the 100 billion. First of all, in that initial 50 billion. So in that first 50 billion, 30 billion of it is what most of you, hopefully, received a couple of weeks ago. And this was all based on Medicare fee-for-service calculations. I know a lot of people are still trying to calculate how that was calculated originally, trying to reconcile it, make sure they got what they thought they should have gotten so that they can try to challenge it, etc. Now they've come out talking about the next 20 billion, because there's 20 billion left to come out. And ultimately, what their whole intention is that this 50 billion is to support all healthcare providers as equitably as possible. Now, that's all going to be in the eyes of the beholder as to what everybody deems to be equitable. But this $20 billion that's left is to be used to augment the original allocations. So what if they're going to look at is, if they were just, from what we can see, is if they were going to allocate the 50 billion, how would they have allocated that in total? And then with that, you know, what amount would they have to augment from what they already provided you? So we are going to see some providers that are probably going to get a lot more than they got the first time. We're going to see a lot of providers that are going to get a lot less. And it would not surprise me if we get some providers that say you already got everything that you're going to get, because of the way they're talking about this. Now, they're going to base this on your 2018 cost reports. Non-cost report providers are going to have to submit information into a portal. And so let's talk about the portal. Portal was activated on April 24th. So basically what they're looking to do is collect and verify information. We recommend everybody go out there and do that. You know, even if you already got your cost report files in there, we're gonna have people that need to put other information in there. And so we've laid in here what else everybody else is gonna need to look at doing. Definitely get to the portal and get this information in, because what they're gonna be looking at is total revenues now. That's how they're looking to, it sounds, to disperse that next 20 billion and reconcile it to the 50 billion. Next slide just talks a little bit about a couple of things that you need to be aware of, is that, you know, you did have the terms and conditions in the initial piece. And with that, you know, it talks about the fact that you're going to have to submit some 2018 data, either when you get the repayment or within 30 days. It also says that you're going to consent that DHHS can publicly disclose the payment of the recipients. So there's gonna be a lot more publicity out there, a lot more going on with that. So make sure you're reading everything in those attestations and those terms and conditions, so you know what you're signing up for, what your obligation is. I tell everybody that none of this money is free. There's always some sort of reporting or component on the back end that we are gonna have to look at. Let's hit that next slide. A couple of other things in here. I know some people have been trying to reconcile the payments, trying to get the calculations. I wish we had all the calculations. HHS is very clear that there is no appeals or dispute process. They're not taking direct inquiries from providers. No revenue or appeals process are available. I don't like that as an answer. We just need to know that that's the position that they've taken. And if we do a lot of work to argue that we didn't get what we should have, it may be a lot of work for not, based on the position that they've taken. On this extra 20 billion and the reconciliation, you know, HHS will be processing applications in batches every Wednesday, and they will not be dispersed on a first come, first serve, they say. But at the same time, while they say that everyone will be given equal consideration, we recommend people get their applications in quickly. And the reason being is that once the money runs out, it runs out. So while it may not be, in essence, a first come, first serve, it is definitely, when the money is gone, the money is gone. Also, ensure that the information submitted is both complete, accurate, or at least you put together as much supportable information as possible in the case of like lost revenues, because obviously that's not an exact science. You're going to have to be able to lay that out. All right, so $10 billion. $10 billion has been targeted for the high impact providers. This one I'm just putting out there because applications were already due on the 25th. And so this is already going out there, formula not published. So I'm sure that, you know, what we're expecting to see is they're going to use the information above as well as DISH to kind of look at how they're going to pay that out. Next one. This is another 10 billion targeted for rural providers. So this is a lot of rural hospitals, rural health clinics, $10 billion based on operating expenses. Since they're using hospitals and rural health clinics, I'm going to assume, which is a scary thing to do, that they're using Medicare cost reports. That payment is supposed to be as early as this week. I have not heard of any specific payment amounts on this here. It doesn't appear that there's an application process. It wouldn't surprise me if it comes out very similar to how the first 30 billion came out in our original funds. Then there's this new 75 billion. So the big piece here is let's watch for some details. All right, some closing thoughts on funding. You need, and I cannot stress this one enough because I am really scared that we're going to have some people get in trouble on the back end. Double dipping. We need to understand where the sources are coming in and how we're using these funds. If you look at all of these pieces, they talk about having to be able to support what you spent this on or how it was used through lost revenues or unplanned expenses, additional expenses around COVID and all that. It's great that we're getting a lot of cash coming through these doors right now, but we really need to make sure that we don't have it taken away from us on the back end through some of the audits that they're talk about. From this, the bill that was passed last week, the Paycheck Protection Program and the Healthcare Enhancement Act, this is straight out of it. These funds may not be used to reimburse expenses or losses that have been reimbursed from other sources or that other sources are obligated to reimburse. So we got to make sure we're not double dipping, counting something twice, because I think the audits could get pretty ugly. So begin your plan. The plan, develop your streamlined strategy of how you're going to gather data. As in any case, whenever you plan it on the front end, you can put together a better plan, make sure it's more streamlined, make sure you have the data at the back end. You're going to have ongoing data gathering. Hopefully by doing all this planning, you can reduce the potential for rework. We all know what that's like when you get to the end of a cost report year and you got to recreate something that you didn't have. Recreating could be expensive, not just in time, but the potential risk of lost dollars. And finally, we really want to make sure at the end of the day, you're protecting your dollars. The dollars that you're getting that you get to keep. They're not just temporary dollars, but we get to keep them long term. So understand your cash flow. You know, it could be significant inflows right now, but look at the back end after, about tomorrow. Cost report impacts, paybacks, forgiveness, etc. Start looking at future projections. Lost versus recovered volumes, service realignment. Are we going to do the same services we've been doing in the past? Are we going to change things? Are we going to have structural realignment because of everything that's been going on? Think about what you're going to do with telemedicine going forward. How's that going to change your operations? The permanent change in this industry at healthcare delivery is the things we need to start planning for so that we understand what that's going to do to our cash flow in the short run as well as in the long run. And in closing, just to kind of line some things up here, you need to understand the revenue cycle issues. And as Dion said, I thought, the piece that I hear from her all the time is know what's temporary, know what's permanent. So you know what you're going to have to pull back, what you're going to be able to continue on going forward. Address the cost report issues. By all means, make sure you're getting those funding sources in applying for what you can. Document. Tie your, what you do document to individual funding sources. So you have that documentation. Again, document. I will not say that enough because this could get ugly. Understand your long-term cash flow. And with that, I think we're ready to do some questions. All right. I've got a couple here. Dion, I'll just kind of read them off and you and I can figure out who's going to answer them. So under telehealth, how have work RVUs changed from in-person visits to virtual visits to televideo to e-visits? And Dion, have you looked at where the work RVUs have changed? I haven't seen anything specific here because I think most of us have been just trying to figure out how to get the bills processed and paid
Yeah.
out.
Yeah, and I'm not sure what that change may have been. I too haven't looked at it, but when we think about for the telehealth visits from a Medicare standpoint anyway, we're not using the 02 for the distant site provider billing if we're going to be appending the 95 modifier. So there are definitely some times where we are still doing telehealth. Maybe a patient is in the hospital and we're still providing telehealth, and that distant site provider is going to continue to use that 02. But if it's during this public health emergency where the patient is in their home and the provider is in a location, we're to bill the place of service as of the location where they typically would have seen that patient. So if it's in a hospital outpatient area, that's where the provider would have provided those services. Let's say you have like an urgent care set up, you're going to bill that out with the same place of service as if you were seeing that patient in that area. Or if it's clinic, you're going to use that 11 because you typically would have normally seen that patient in the clinic.
There's another question here. It's on for RHCs and the various forms of telehealth. The efficiency payments seem to be impacted since it's not a face-to-face time. What are your thoughts? I think this has to go back to the productivity standards question. If that's what it is, I think I answered, you're gonna have to watch carving out your FTEs and everything to make sure that you're whittling that out. That's gonna take a lot of tracking, which is not necessarily gonna be fun. Dion, one here for you, I believe. If you are a CAH billing method 2 and are using the GT modifier, do you also need to have the 95 modifier for Medicare?
No, when you're billing on the UB as a method 2, now again, this would be when you have a physician who has reassigned their benefits to the critical access hospital, and they would have normally been in the hospital providing that service. You would bill that out then using that GT modifier, but you don't need to put both.
Okay, another one I think that goes to you, Dion. You're popular. Yesterday, we were on a call with CMS that stated we needed the CG modifier on the RHC claims and that this may help with payment processing, and they will be issuing new guidance. Have you heard this?
Yeah, so while that initial instruction that came out did not include, it said that we would send the claim with the 95 modifier. It did not say the CG, but what we do know is that in the rural health clinic, if you have a type of bill of 711, you're not going to get paid your all-inclusive rate without that CG modifier being present. So we do expect them to clarify that.
Let's see, for uninsured patients. Let me see here. Okay, for uninsured patients, do we have to have tests to support positive COVID diagnosis in order to bill this?
I do not believe you do, because they have said that, it will be based on having that positive or the provider's clinical documentation that the indication to them is that the patient is positive. So if you're going to be putting on the diagnosis, I think that's what's going to drive it. But again, we don't have clear instruction yet on that.
I've read that accelerated payments were suspended for only Part B providers, but Ralph is indicating for all. Could you please clarify? My understanding from what we have heard is that it was for all, but everything is subject to clarification and interpretation as these rules continue to move fast. Is it possible to break HHH payment, provider relief payment, between hospital and its provider-based RHCs? If you're talking about receiving it, as it's coming in, they're just dropping it into the main provider. So I don't know of any way that you'd be able to have them break that out, unless at some point in time they give you some sort of calculation of how they came up with the total, and you can do that internally. Let's see, it says, if we didn't receive additional funds in the second wave from the provider relief money, do we need to go to the portal and submit our revenue data? If you haven't received anything yet, that portal came out on Monday. I would go out and do that. Make sure you've got all the data that they've asked for. It is possible, because I've seen some providers where we believe they've actually gotten all they're going to get and they're not going to get any more. I've seen a couple providers where some of the calcs that some entities put together actually thought they might have go backwards. Now, I haven't seen anything talking about recoupments or anything, but remember, this was supposed to do it equitable at the $50 billion level. So if somebody did get more than they would have calculated at the 50 billion level, that would be something that HHS is going to have to talk about there. Previously, we had been told to use CG and 95 modifier on the telehealth visits. Is this still the case if the visit is not COVID related?
That is correct. So the CG means that that is the line that you have rolled all your non-preventative charges into on your UB. The 95 tells them it was telemedicine. If it's COVID related, you would also then have the SC, or the CS appended to it, which would waive the deductible and coinsurance amounts.
If a CAH receives partial forgiveness of a PPP loan, how will those expenses that were not forgiven be treated on the cost report in regards to the calculation of the CAH's cost reimbursement? That is an unbelievably great question, from the aspect that we don't know what they're going to do with the loan forgiveness amount yet. Will they make us offset that? Will they treat it as a grant? At this point, I would argue that anything that where those expenses were forgiven, we want to be able to separately identify that, because most of us that we work with in the industry, ourselves, some of our our colleagues in other firms and everything, we're all trying to take the position that this is a grant, and grants, if you go into the PRM1, would say that those are not offset. But this is all subject to interpretation and clarification from CMS. I've heard some states where they've said, where Medicaid reimburses on cost, that they are actually planning on having you offset any amounts that were forgiven or granted. Definitely something we have to watch. If you're conservative, I would be conservative, assuming that they're going to make you offset it. Look at what it's going to be if it isn't offset. Figure out what your financial risk is there, so that you can plan as well as possible as the industry continues to work to get more clarification on this issue. Billing on the UB as a CAH method 2 in the clinic, should we be using the CS modifier? I am under the impression that from NGS that the CS modifier is only for 1,500 Part B claims. Is this accurate, or should we be using it?
The CS would be, my understanding, or how we're interpreting that, is that you use the CS. That's the indicator that tells Medicare that they should waive the deductible and coinsurance. So it would be on either your 1,500 or your UB.
Do you need to submit your revenue data in the portal if you've received both payments to confirm revenues? I don't think there's anything that says you have to, but I think the one thing we want to make sure is that CMS has as much accurate information as possible. So I would highly recommend you consider going out there and seeing if there's anything that they are missing that they're asking for, because you don't want to get to a point where they say, well, we shut the portal off and we really asked you for this before and you didn't give it to us and now you can't file it. So I'm just being a little conservative in that one. For the PPP forgiveness calculation, are they only carving out the portion over 100K or 100% of that employee's salary over 100,000? It's just the amount over. You can take up to the 100 is my understanding on that one. And let's see if we can grab one more question here. HCPC codes G2023 and G2024 have been established to bill for specimen collections for COVID-19 testing. Are those billable by hospital-based labs? We're receiving conflicting guidance that this only pertains to independent labs.
That is our understanding as well on that.
Understanding is that they're only billable by independents?
Independent labs, yes.
Amy, with that, we'll turn it back over to you to wrap this one up. I mean, maybe as I close out my part of it is just thank you for all the questions. There's never enough time to answer everything that comes through, but greatly appreciate those questions that were posed.
Awesome. Well, thank you all so much. And if we didn't get to your question, we will pull that report and we can answer them offline later this week as the presenters are going through everything. And this recording will be available. Once it is edited and ready to go, we will email out that link. So give us a few days to get all that going, but we will email you that recording. So thank you, Dion. Thank you, Ralph. And I hope everyone has a great day.